Hello everyone and welcome to our video on anxiety disorders. Let's start by talking about panic attacks. Panic attacks are the sudden onset of intense fear. Panic attacks often occur in many patients with no trigger, although sometimes they are also triggered by a stressful life event. For example, if someone comes up to you and says all the money you had in the stock market is gone, you could have a panic attack. They're brief, they only last for a few minutes to an hour, and then they resolve on their own. Panic attacks are associated with physical symptoms that are caused by the fear or panic, and many patients having panic attacks will go to the emergency room thinking that they are having a heart attack or some other disorder, not a psychiatric problem. Some of the symptoms you may see among patients with a panic attack are palpitations and a racing heartbeat, sweating, trembling or shaking, and chest pain or discomfort. According to the DSM-5, in order to have a diagnosis of a panic attack, a patient must develop 4 or more of the following. Now, most of these are obvious, like the things we talked about on the last slide, and I won't go through every single one of them. You can read about them if you wish. But the last two are somewhat unusual: derealization and depersonalization. So let's talk about those now. Patients who have derealization as part of their panic attacks will tell you that items in the room around them look foggy or unreal. Sometimes they will also say that they feel like they're in a foreign place, even though they're at home in their bedroom, and this is often intensely scary. It's called derealization because the patient feels like the room around them is not real. In depersonalization, patients will tell you that they have an out-of-body experience during their panic attacks. They will feel detached and looking down at themselves from above. So many patients know about the sweating and the palpitations and the other physical symptoms of panic attacks. What's less well known are these two symptoms shown on this slide. Many people will have one or an occasional panic attack. For example, many medical students will have a panic attack the night before a big exam. But panic disorder is something separate from panic attacks. People with panic disorder have recurrent unexpected panic attacks. These patients complain of panic attacks that seem to come out of the blue. In addition, the panic attack can't be part of another disorder. So for example, many patients with post-traumatic stress disorder, which we'll talk about later, will have panic attacks. Those patients don't have panic disorder. In addition, patients with phobias like a fear of flying can have panic attacks. Those patients do not have panic disorder. Additionally, the attacks have to be followed by 1 month or more of persistent concern or worry about having a panic attack and changes in behavior to avoid attacks. So these people are having unexpected panic attacks, and in between attacks, they are very worried about them. That defines panic disorder. Panic disorder tends to occur in young adults. The median age is 24 years. It's twice as common in women as in men. There are a couple of well-described risk factors you should be familiar with. The first one is a genetic component. So if a patient has a first-degree relative with panic disorder, they are at much greater risk than the average person. Patients who have a history of physical or sexual abuse are more likely to develop panic disorder. And then patients who have significant life stress are more likely to develop panic disorder. For example, patients working through a very difficult and stressful time at their job or in their marriage can sometimes develop panic disorder. There are a number of treatments. Cognitive behavioral therapy is often used. Antidepressants, especially SSRIs, can be effective, and benzodiazepines are also often used. Moving on, let's talk about generalized anxiety disorder. In this disorder, patients suffer from chronic, persistent anxiety. The anxiety is over many different events or activities in their lives. Patients with this disorder will often say they feel like they are worried about everything in their life. Symptoms have to last for at least 6 months, and they have to have symptoms for more days than not over the course of at least 6 months. In addition to symptoms for at least 6 months, according to the DSM-5, for patients to meet the criteria for generalized anxiety disorder, they must have 3 or more of the following present: restlessness, fatigue, difficulty concentrating, irritability, muscle tension, and sleep disturbances. So if patients have chronic persistent anxiety for at least 6 months and they have 3 or more of the following features, then they meet criteria for generalized anxiety disorder. Now let's talk about specific phobias. Patients who have a specific phobia are afraid of a specific object or situation, and this leads to avoidance behavior, meaning they engage in activities to avoid the object or situation that they're scared of. Symptoms have to be persistent for at least 6 months, and there are many specific phobias that have been described. You may know many people who are afraid of flying. There are people who are afraid of going to the dentist or having their blood drawn. So patients who are afraid of one of these things and engage in avoidance behavior may meet the criteria for a specific phobia. Besides specific phobias, there are 2 other disorders that you should be familiar with for step 1. In many ways, these resemble specific phobias, but according to the DSM-5, they are separate, unique diagnoses. The first one is social anxiety disorder. This is a specific phobia of social settings. And what patients with a social anxiety disorder are afraid of is embarrassment when they're in a social setting. They're afraid of being humiliated and judged. So although this sounds like it could be a specific phobia of embarrassment, it has its own diagnosis, social anxiety disorder. Second disorder is agoraphobia. Agora is a Greek word for public space. So people with agoraphobia fear leaving a safe place like home for a public setting. And what they are afraid of is they're afraid of needing to flee with no help available. And this is a key distinction, especially for answering board questions. They are not afraid of scrutiny or embarrassment in public. If they are, then they have social anxiety disorder, not agoraphobia. What agoraphobic patients are afraid of is being unable to flee out in a public setting and being unable to get to a safe place. So for example, someone who has agoraphobia may fear being on an empty bus, even with no people. It's not the people they're afraid of, it's being trapped on the bus. Agoraphobia often occurs together with panic disorder, and often what patients fear who are agoraphobic is they fear developing a panic attack when they're out in a public setting and can't get to a safe place to calm down. There are some medications that can be used to treat patients with specific phobias. Benzodiazepines are often used for infrequent exposure. For example, patients who are afraid to fly will often take a benzodiazepine before they get on the plane, and then they'll be able to tolerate the flight. Beta blockers are sometimes used. These will blunt some of the physical symptoms like sweating and racing heartbeats. And then finally, SSRIs can be used for patients who are afraid of something that they are frequently exposed to. Specific phobias often respond to behavioral therapy, and there are a couple of subtypes of behavioral therapy that often work for these disorders. The first one is called systematic desensitization. In this type of behavioral therapy, the patient imagines exposure to the feared stimulus. For example, they imagine going to the dentist's office, and they're taught to relax themselves and not have the panic response. In exposure therapy, the patient is confronted with the feared stimulus in a safe and controlled manner. So, for example, the patient may go with their therapist to the airport and try to get used to being around airplanes, and they're taught to reduce their fear over time. This is called extinction learning. Now let's talk about obsessive compulsive disorder, or OCD. As the name implies, this disorder involves obsessions and compulsions. So an obsession is defined as a recurrent, persistent thought, urge, or image. It's an obsession. It's something the patient can't stop thinking about. The thoughts are intrusive and unwanted. The patient doesn't want to think about what their obsession is, but they can't help it. And the patient will often attempt to ignore or suppress the obsession, but they can't, and this causes distress. A compulsion is a repetitive behavior or mental act that the patient does to relieve the obsessions. For example, if the patient is obsessed with the fact that there are germs on their hands, they may engage in compulsive hand washing. Another classic obsession is that the stove may be turned on and is going to burn down the house, and patients with that obsession may compulsively check the stove to make sure it's turned off. Other things patients may do as compulsions include praying, counting, repeating words. The patient feels driven to perform these compulsions as a response to the obsessions. The compulsions seen in obsessive compulsive disorder are often described as ego dystonic. So let's talk about what that means now. The ego is what mediates between your id, which is your desire, and your superego, which are the rules of society. Patients that engage in ego-syntonic behavior engage in behaviors that achieve the goals of the ego. In other words, behaviors that achieve their desires. Patients who have obsessions or compulsions that achieve their goals are said to have ego-syntonic compulsions. And this is what's seen in obsessive compulsive personality disorder. These patients will have obsessions and compulsions, like maybe they're obsessed about their job and they compulsively work on the tasks at their job. But those obsessions and compulsions are achieving their goals of doing a good job at work. So those are ego-syntonic behaviors, and that's what's seen in obsessive compulsive personality disorder. In obsessive compulsive disorder, which is what we're talking about now, patients engage in behaviors that conflict with the goals of the ego. So in OCD, the obsessions and compulsions are barriers to the goals. So for example, the patient wants to get out of the house and lead a normal life, but they have to keep checking the stove. That is a compulsion that is ego dystonic. It's serving as a barrier to their id or their desire. This is what's seen in obsessive compulsive disorder. OCD commonly co-occurs with other psychiatric disorders. Many patients with schizophrenia and schizoaffective disorder have OCD. Many patients with bipolar or eating disorders have OCD, and some patients with Tourette's have OCD. The treatment is with behavioral therapy and drugs. The specific type of behavioral therapy that's often used is called exposure and response therapy. The patient is exposed to their obsessive thoughts or images. For example, they're exposed to their stove that they have to keep checking, and they're taught to respond in a non-compulsive way with some form of non-compulsive behavior. In addition, drugs are also used as well, like SSRIs, and a particular tricyclic antidepressant, clomipramine, is often effective for OCD. Moving on, let's talk about body dysmorphic disorder. This is a disorder that occurs in people with physically normal bodies, but they are preoccupied with their physical appearance. Patients with this disorder often focus on non-existent or minor defects. They may say that their shoulders are abnormal or their legs are abnormal, but they look perfectly normal. The patient believes that something about them is abnormal, ugly, or deformed, even though there's no evidence of that. And this leads to repetitive behavior, like checking themselves in the mirror over and over again, combing their hair over and over again. This is basically a variant on obsessive compulsive disorder, where the obsession is the appearance and the compulsion is checking the appearance. And it's treated just like obsessive compulsive disorder with CBT and drugs. Post-traumatic stress disorder, or PTSD, is an anxiety disorder that follows a traumatic event, for example, a rape or a physical assault. Many soldiers return from war zones with PTSD over things that they saw, like friends being injured or killed. Patients will complain of thoughts, nightmares, or flashbacks that involve the trauma that they witnessed. They will avoid things that remind them of the trauma. Often, because of the trauma they experience, they become hypervigilant, so they can be anxious, alert, and scanning around them, looking out for predators or someone coming after them. They often complain of sleep problems. They say they feel restless and they can't fall or stay asleep, and this leads to social dysfunction. Some of the diagnostic criteria for PTSD are shown on this slide. The patient has to have been exposed to a traumatic event. The trauma has to be persistently re-experienced, as I said before, through thoughts, nightmares, or flashbacks. They have to avoid trauma-related stimuli. They have to have negative thoughts or feelings after the trauma, and they have to have trauma-related arousal or reactivity. This refers to things like the alertness and scanning that I talked about on the last slide. And then finally, symptoms have to last for more than 1 month. So people who experience a trauma may have a week or so of PTSD-like symptoms. They do not have PTSD, but if the symptoms persist for more than 1 month, then they may meet criteria for this disorder. Some of the treatments for PTSD are shown in this slide. Therapy is often used. SSRIs are often used. And then one special therapy you should be aware of, this sometimes comes up on board exams, is prazosin. Prazosin is an alpha-1 blocker, and it's been shown to reduce nightmares and improve sleep. The thought here is that it blocks some of the sympathetic activation that occurs in patients with PTSD. I talk about this drug in the cardiology video on hypertension drugs, but because it's an alpha-1 blocker, it may cause orthostatic hypotension as a side effect. Acute stress disorder shares many similarities with PTSD, but it has a couple of unique features that should help you to distinguish it from PTSD in a board question. Acute stress disorder also follows exposure to some trauma. For example, threatened death, like if a patient almost dies in a car crash, that can lead to acute stress disorder, a major injury, or a sexual assault. Also similar to PTSD, acute stress disorder can involve recurrent intrusive memories and recurrent distressing dreams. But the two things that will help you distinguish acute stress disorder from PTSD are dissociative symptoms and the time frame. So dissociative symptoms are complaints from a patient that they feel like they're in an altered sense of reality following exposure to the trauma. They may say they feel like they're in a daze and that time is slow. Sometimes they can't remember important aspects of the trauma. This is called dissociative amnesia. So these symptoms collectively are called dissociative symptoms. And if they occur in a patient following a trauma, that's much more suggestive of acute stress disorder than PTSD. The other special feature of acute stress disorder is that it always lasts less than 1 month. If symptoms like this persist beyond a month, then the patient has PTSD, not acute stress disorder. And clinically, it's important to distinguish this from PTSD because the treatment is with therapy but not drugs, and that's in contrast to PTSD, which is often treated with drug therapy. Separation anxiety disorder is a childhood anxiety disorder. Children with this disorder have extreme distress when separating from their home or parents. It's normal for kids to have some fear of leaving their parents, but in separation anxiety disorder, that fear is exaggerated. So the child may refuse to leave home, may refuse to go to school. Other features are the child may worry about losing major attachment figures like their mom or dad, and there's persistent reluctance or refusal to go out of the house and go to places like school. Some children with separation anxiety disorder complain about nightmares related to separating from their mother or father. In addition, many children complain of physical symptoms so that they can stay with their mom or dad. And this is something you need to know about when you're on your pediatrics rotations. So some children will complain of headaches or upset stomach or nausea. This often occurs when they're separating or in anticipation of separating. So a child with recurrent headaches or belly pain that's unexplained that occurs whenever they're about to go to school may have separation anxiety disorder. The treatment is usually with therapy. The goal is to teach children coping skills. Cognitive behavioral therapy, where a therapist meets with a child, is often used. And there's a special form of therapy called parent-child interaction therapy, where a therapist sits behind a mirror and communicates with a parent through a microphone in the ear, and the parent is coached to try and interact with a child in a specific manner to help reduce separation anxiety. And that concludes our video on anxiety disorders.